Welcome to Week 10. We're shifting from epidemiologic methods to epidemiologic applications. Today we cover screening, finding disease early in apparently healthy people, and surveillance, monitoring disease patterns in populations. For healthcare managers, these are directly practical topics. You may be responsible for implementing screening programs, ensuring screening guidelines are followed, or using surveillance data for planning. Understanding the principles helps you make better decisions about these programs. Screening is the application of a test to people without symptoms to identify those likely to have a disease or risk factor. The logic seems intuitive: find disease early, treat early, improve outcomes. But screening is more complex than it appears, and not all screening is beneficial. Screening is a population-level intervention. You're testing people who feel fine, most of whom don't have the disease. This is fundamentally different from diagnostic testing, which is applied to people with symptoms who present for evaluation. For screening to be worthwhile, several conditions must be met. The disease must be important and treatable. Early treatment must be more effective than treatment after symptoms appear. The test must be accurate enough and acceptable to the population. Many screening programs have proven beneficial: cervical cancer screening, newborn metabolic screening, mammography for certain age groups. Others have been shown to cause more harm than benefit. Understanding screening principles helps you evaluate programs. To evaluate screening tests, we start with sensitivity and specificity. Sensitivity is the proportion of people with disease who test positive. A sensitivity of 90% means 90 out of 100 diseased people are correctly identified, 10 are missed, false negatives. Specificity is the proportion of people without disease who test negative. A specificity of 95% means 95 out of 100 healthy people are correctly identified, 5 test positive despite being healthy, false positives. There's usually a trade-off. If you lower the threshold for a positive test, you catch more disease, higher sensitivity, but generate more false positives, lower specificity. If you raise the threshold, you miss more disease but have fewer false alarms. No test is perfect. Even excellent tests misclassify some people. The question is whether the benefits of correct classification outweigh the harms of misclassification. Threshold setting depends on consequences. For a deadly, treatable disease, you might accept lower specificity to avoid missing cases. For a condition where false positives lead to harmful interventions, you might demand higher specificity. While sensitivity and specificity are test characteristics, predictive values tell us what results mean for individual patients. Positive predictive value is the probability that a person with a positive test actually has the disease. If PPV is 80%, then 80% of those who test positive truly have disease, 20% are false positives. Negative predictive value is the probability that a person with a negative test truly doesn't have disease. Here's the critical insight: predictive values depend on disease prevalence. The same test performs very differently in different populations. With a test that's 95% sensitive and 95% specific, screening a population with 1% disease prevalence gives a PPV of only about 16%. Most positive results are false positives. But in a population with 50% prevalence, the same test has PPV of about 95%. This is why population screening differs from diagnostic testing. In symptomatic patients with high disease probability, positive tests are likely true positives. In asymptomatic populations with low prevalence, many positive screens are false positives requiring follow-up testing. For healthcare managers, this means understanding that screening programs generate many false positives that need workup. The Wilson-Unger criteria, published by WHO in 1968, remain the standard framework for evaluating screening programs. Disease criteria: the condition should be an important health problem. The natural history should be understood, including a latent or early symptomatic stage. Disease should be detectable during the early stage. Test criteria: a suitable, acceptable test should be available. It should be safe and reasonably accurate. The population should find it acceptable. Treatment criteria: effective treatment should exist. Early treatment should be more beneficial than treatment after symptoms develop. Treatment facilities should be available. Program criteria: the screening program should be cost-effective considering all direct and indirect costs. Continuous, quality-assured operation is needed. Access should be equitable across the population. Not all possible screenings meet these criteria. PSA screening for prostate cancer has been controversial because early treatment may not improve outcomes compared to watchful waiting, and treatment has significant side effects. Before implementing or endorsing a screening program, evaluate it against these criteria. Canada has several established screening programs, guided by the Canadian Task Force on Preventive Health Care. Cervical cancer screening with Pap tests has dramatically reduced cervical cancer mortality. Guidelines now recommend HPV testing as primary screening for eligible women, with screening starting at age 25 in most provinces. Breast cancer screening with mammography is recommended for women aged 50 to 74. There's ongoing debate about screening women aged 40 to 49, where benefits are less certain and harms from false positives are more common. Colorectal cancer screening using fecal immunochemical testing, FIT, or colonoscopy is recommended for adults aged 50 to 74. Organized programs exist in most provinces. Newborn screening tests all newborns for treatable metabolic conditions like PKU and congenital hypothyroidism. Early detection and treatment prevents severe developmental consequences. The Canadian Task Force provides evidence-based recommendations, updated as evidence evolves. Their guidelines influence provincial screening programs and clinical practice. As healthcare managers, you implement these programs, track participation rates, and manage the cascade of follow-up for positive screens. Surveillance is the ongoing systematic collection, analysis, and interpretation of health data for public health action. Unlike research studies with defined endpoints, surveillance is continuous. It monitors population health over time, detecting trends, outbreaks, and emerging threats. Surveillance data informs action. It's not just academic, it triggers investigations, guides interventions, and evaluates programs. Passive surveillance relies on healthcare providers reporting cases. It's less resource-intensive but may miss cases. Active surveillance involves public health actively seeking cases through laboratory queries, record reviews, or surveys. It's more complete but more expensive. In Canada, certain diseases are notifiable. Healthcare providers must report cases to public health authorities. The list varies by province but includes tuberculosis, measles, HIV, and many foodborne and sexually transmitted infections. Syndromic surveillance monitors symptom patterns, emergency department chief complaints, pharmacy purchases, for early outbreak detection before specific diagnoses are made. For healthcare managers, understanding surveillance helps you contribute data, interpret public health alerts, and use surveillance information for planning. Let's summarize screening and surveillance. Screening applies tests to apparently healthy people to find disease early. It's a population-level intervention with different dynamics than diagnostic testing. Sensitivity and specificity are test characteristics. Predictive values tell you what results mean for individuals and depend critically on disease prevalence. In low-prevalence populations, even good tests generate many false positives. Most positive screening results require follow-up testing for confirmation. Understand this when managing screening programs. Wilson-Wiener criteria provide a framework for evaluating screening programs. Important disease, acceptable test, effective early treatment, and feasible program implementation are all required. Surveillance is ongoing monitoring of population health. It detects trends and outbreaks, informing public health action. Notifiable disease reporting is a key surveillance mechanism. For healthcare managers, these tools help you implement screening effectively, interpret surveillance data, and contribute to population health monitoring. Next week, we cover outbreak investigation, epidemiology in action during health emergencies. See you next week.